You too, Ryan. Good morning. I'd like to call the meeting of the board to order. Will the secretary please call the roll?
Director Bott,
Present.
Director Garza,
Present.
Director Green. Present. Director Harrington,
Present.
Director Kim. Present. Vice Chair Lowry,
Present.
Director Ryder,
Ryder is here.
Director Robinson,
Present.
Director Sorrell is absent, Director Webster Cross,
Present.
and Chair Taylor.
Present.
You have a quorum.
Thank you. The next regular meeting of the board is scheduled to be held on Friday, March 28th at 9 a.m. To begin, I'd like to entertain a motion to allow Directors Garza and Webster Cross to remotely participate in this meeting as voting members. So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none. All in favor?
Aye.
All opposed? The ayes have it, the motion carries. Thank you. To begin, I'd like to take my report out of order to recognize the recent passing of the Honorable Jerry Butler, our former board vice chair and a longtime member of the Cook County Board of Commissioners. Commissioner Butler, as many of you may know, was an inaugural member of the CCH board since its creation in 2008 and served as vice chair from 2014 until his retirement in 2018. He was a dedicated public servant and staunch champion of the residents of Cook County, and he had a particular focus on addressing health care equity. I will use that word, health care equity. His contributions to CCH and Cook County are immeasurable. He will truly be missed and will always be remembered. I believe Vice Chair Lowry would also like to have a few words, followed by Director Ryder and Dr. McInnes, as well as any other directors.
Thank you, Chair. I really appreciate it. You know, for almost 33 years, Commissioner Jerry Iceman Butler was truly a leader. Many know him as a trailblazer relative to the arts, but he was also in many ways a trailblazer relative to his service on behalf of all of us throughout Cook County. And the story goes when he first began serving as Cook County Commissioner, he was meeting with a group. And while he wanted to not only listen, but wanted to share with the group his vision relative to his service, which, as the chair said, would be rooted in transparency, a real commitment to healthcare equity and accessibility. He was talking to the group, and they kept saying, "Sing, Jerry, sing." And he said to those who were with him, he said, "No, I'm not going to sing. I'm not going to sing. This is a different space for me. Sing, Jerry, sing." So they saw another group, and without even prompting, with no prompting at all, he started "Only the Strong Survive." And the group really enjoyed that, and that really just shows who he was. He embraced his celebrity, but he did so because it was that celebrity which allowed him to serve, and that was really who he is and what he did. And he did that well for almost 33 years as a Cook County Commissioner. He did that well as he served as a chair of the Board of Commissioners Health and Hospital Committee. And I'm so grateful that we had a relationship. So when I reached out to him when I first ran, he actually endorsed me almost 7 years to the day. It was February 27th, 2018. And on that day, he noted, "For nearly 3 decades, I've served the people of Cook County's 3rd District, and I'm now passing the baton to Bill Lowry. We need someone in county government with integrity and vision." And I can say in all truth that each and every day I have brought integrity to the job, and I hope from time to time I've brought some vision. I last spoke to the commissioner in November because I would check on him every other month or so, but also I'd call him when someone in the community would ask me how is he doing and could they have his phone number. But I'd never give his phone number without speaking to him. So I called him and I said, "Commissioner, so-and-so would like your phone number, is it okay?" And he said to me, "Yes," as he always did, but then he paused and he said, "Thank you for asking me." And at that point, I wished him a happy holiday, and he returned that. So again, I appreciate his legacy. I appreciate his friendship. And I will say this, he is now not only in a better place, but he is reunited with his lovely bride of 60 years as he goes forward. So I will continue to serve as his successor. I will continue to serve as his successor as Chair of Health and Hospitals for our board, and I will do so always with two words in mind: integrity and vision. Thank you.
Dr. Ryder.
Thank you, Mr. Chairman. I think it's difficult to talk about the Iceman without talking about both of his roles that are significant here to people here in Chicago and all over the country. So, you know, my time with Commissioner Butler, we overlapped on this board towards the end of his tenure, when, you know, his health issues, I believe, were starting to accumulate, and you know, he soon handed off his leadership role at the county to Bill. But he served as a very significant person and supporter of this institution, which I think reflected his values as a person and his support for working people, as this hospital has been maintained. You know, I have people in the labor movement who fight for this hospital, not because of the jobs it has at the hospital, but as the importance as a community institution that it provides to people who have that don't have access to the big fancy places or you know, emergency room runs that are picked up by other institutions. And I was talking to one of my mentors in the labor movement, Rose Daly, who's a retired leader from AFSCME. She was the assistant executive director. And I said, you know, and her main responsibility was dealing with the city. But I asked her, like, what was your relationship like with Jerry Butler? And she said, well, it was mostly through the singing. And prior to him becoming commissioner, he had helped by offering his talents to events put on by the Coalition of Black Trade Unionists, which is a constituency group of the National AFL-CIO, where we have one of the original chapters here in Chicago. And this is before he became a commissioner. He had no political incentive to participate in this event other than to help like this cornerstone activist organization, the labor movement, which was originally founded here in Chicago, to help them raise money to further the cause of Black union members here in our city. For such a notable figure who ended up in the Rock and Roll Hall of Fame to lend his time to support Black union members here by offering his talents to help raise money and awareness of their cause, while it seems small in the grander scheme of things to people who are reading all the tributes to him, it's significant to me because it's a further intersection of where he would go with his life when he became commissioner. What was it, 1985? And you know, his support for all of us here in Cook County. Bill may argue with me on this point. Being a Cook County commissioner is not a sexy position, right?
There's no argument.
You know, I think we hold them up on a pedestal here in these institutions where we know they matter. But when you look at all the sexy jobs in government, people think about aldermen, they think about state senators, they think about their folks in Congress, and you know, commissioners don't get necessarily access to the types of resources or face-to-face engagement that ground-level services that aldermen provide. They're not passing big statewide policies in Springfield. What they're doing is they're they're catching ground balls and throwing people out at third all the time. The county acts as an enormous safety net, for over 100 communities, here in our little part of the state, which is a big deal. So, you know, Jerry Butler didn't become a commissioner in Cook County just because it was a cool job. He did it to serve his community.
Thank you, Chair Taylor. Good morning. On behalf of the Cook County Health Team, I just want to share how deeply saddened we are by the passing of Commissioner Jerry Butler. He was a distinguished public servant and integral member of the Independent Board of Directors, as we've heard. He served as an inaugural member in 2008, continued his service for a decade, and that included 4 years as our vice chair. He was a steadfast advocate for health justice and was instrumental in the creation of County Care. His leadership and commitment to public service left an indelible mark on our health system in the entire county. We extend our deepest condolences to the Commissioner's family, his friends, and all who were touched by his remarkable life and legacy of both music and service. Thank you.
Thank you. Any other directors have any comments or questions? Thank you. Thank you for your comments. And let the record reflect that the Cook County Board of Health Board of Directors extends its sympathy and condolences to the family of Commissioner Butler. He will be missed, and we thank him sincerely and his family for their service to us. The first item on today's agenda is employee recognition, which will be reviewed by Dr. Michaelis. Am I correct?
Yes, sir. Thank you, Chair Taylor. Good morning again. As always, we'll start with our new hires. There we go. We welcome Lisa Ye, Chair of the Division of Child and Adolescence and Psychiatry. Josuni Iglesias, Residency Director, Internal Medicine Primary Care Program. Kevin Hickey, Director of Quality Improvement, Quality Assurance. Julian Feldmeth, Senior Manager of Policy and Innovation, Health Plan Services. Daniel Byers, Senior Manager of Complex Care Coordination, Community Care. Jaime Martinez, Manager of Operations, Bilingual, North Riverside. Meg Kroll, Occupational Therapy Manager, Providence. Karen Lewis, Quality Data Manager, Quality Assurance. Rocio Vargas Garcia, Ambulatory Clinic Manager, Department of Public Health. Candace Nix, Manager, Community Immunization Program, Department of Public Health. And congratulations to those who earned promotions over the last month or so. Raji Thomas, Chief Quality Officer, Quality Assurance. Alex Normington, Chief Communications and Marketing Officer, Administration. Sharon Welbell, Chair of the Division of Infectious Disease. Thomas Gass, Chair of the Division of Interventional Radiology. Justin Gandia, Chair of the Division of Gynecology, Obstetrics and Gynecology. Mariko Limpar, Medical Director, Employee Health Services. Nancy Quezada, Director of Pulmonary Care Administration. Nagista Dacey, Physician Advisor, Medical Administration. Raymond Narr, Physician Advisor, Medical Administration. Carla Anderson, Director of Psychology, Student Training, Psychiatry Administration. Therese Swice, Director of Health Psychology Services, Psychiatry Ambulatory. Ashante Wells Baines, Director of Administrative Operations, Medical Administration, and Kelly Lynn Matoyer, Senior Project Manager, OBGYN Administration. Congrats to you all.
Congratulations. Well done.
Okay, and some recognitions and announcements. We celebrated American Heart Month earlier this month. We had our Cook County health leaders, elected officials, and one of our patients came together to recognize improvements in access to advanced cardiac care. And we celebrated this with a press conference on February 11th. And of course, yeah, as we go through this, please stand and be recognized if you're involved in these projects. Cook County Health has invested about $6 million in the cardiology service line over the last few years to provide new technologies to patients, including TAVR procedures, MitraClips, which are part of our structural heart disease program, as well as Impella devices, which provide advanced life support. And these investments, of course, have increased access to cutting-edge cardiac care for our communities and have saved lives. Congratulations.
Well done. Thank you.
Congratulations as well to our nursing team for the Nursing Innovation and Research Center's inaugural Evidence-Based Practice and Research Conference that was held on January 28th. We had more than 100 nurse leaders from CCH and other health systems around the region who attended to share best practices and collaborate on advancements in clinical care.
All right,
Congratulations as well to our SimLab team. They were recognized by Becker's as one of 64 hospitals and health systems with great simulation and education programs. Becker's recognized programs that empower students and healthcare professionals to hone their skills in realistic, safe settings designed to mirror real-world scenarios. Do we have anyone from our SimLab team? No? Okay.
well done.
Congratulations as well to Dr. Christoph Firko, Associate Chair, Department of Medicine, Jackie Witten, Chief Nursing Officer, Stroger Hospital, James McCracken, Director of Emergency and Trauma Nursing, and Kathy Minogue, excuse me, Director of Maternal Child Health, for being selected for a Chef Innovations Award. This award recognizes the accomplishments of a healthcare team which has inspired leadership, change, and advancement in the Chicago area healthcare community. It's a testament to the incredible work and dedication of our team, showcasing our commitment to innovation and excellence in healthcare. Congratulations, team.
Well done. Can you clarify what chef is?
Oh, it's, well, let me get this, it's Healthcare Executive Forum.
Chicago.
Yeah,
Thank
Chicago,
you.
thank you.
We use acronyms, everybody
Yeah,
doesn't know.
yeah,
Chicago
that's right. No, it's a great call.
Executive Forum. Thank you.
Congrats as well to Andrea Gibson, Cook County Health Chief Strategy Officer. She was recognized by Becker's on their list of Chief Strategy Officers to know. The list included visionary leaders who help brand, market, and expand their organizations, developing strategies that propel progress. Congrats, Andrea. Congratulations to Dr. Ayubami Olufimihan, General Medicine Physician, for being recognized with a 2025 ASTO GI Symposium Merit Award by Conquer Cancer. The list of awardees included 35 oncologists recognized for their contributions and advancement in cancer research and care. Congratulations.
Congratulations.
In honor of Black History Month, we held a Facebook Live event where we discussed diversity in medicine, representation, and building an equitable health system. Thank you to all of our panelists for a very successful and insightful event. CCH staff as well, past and present, have been featured on our social media pages throughout the month in celebration of the contributions of African Americans in healthcare.
Well done. Thank you.
And just to highlight, we are continuing free COVID-19 and flu vaccine clinics, March 1st at Blue Island, March 8th at Cottage Grove, March 15th at Robbins, and March 22nd at Arlington Heights. And then I just want to take a minute, I'm sure everyone has heard about the incident in Providence over President's Day, and I wanted to take a moment to specifically recognize the team at Providence Hospital who responded so quickly when a patient was attacked, one of our physicians in the emergency department. I want to share my immense gratitude with the Providence team members who sprang into action, disarmed the patient, and got their colleague to safety and rendered care. If you responded to this incident, please stand so we can recognize you. Thank you.
Thank you very much.
This situation had the potential to be tragic, and it's thanks to the quick and decisive actions of these individuals in the room as well as online, excuse me, that further harm was prevented, so thank you again. I'd like to also thank our leaders who rallied to support our team and address their needs, as well as create a decisive action plan. Thank you to our leaders as well. And I'm thankful that our colleague who sustained these serious injuries is recovering. He has our support and our gratitude. The safety and well-being of our staff, our patients, and our visitors remain our top priority. We conducted an RCA on this incident right away and have taken immediate steps to prevent a similar incident from occurring again. We deployed our employee assistance program, which continues to be available for staff 24/7 at no cost, and we will be hosting town halls in the next week or so at Providence to check in again with our staff. We're continuing to enhance our security measures. Additional security staff, piloting wanding procedures, and new panic buttons have been added already to both of our emergency departments. We're continuing to evaluate opportunities to further enhance security at other locations, including our hospital entrances and our ACHN sites. Incidents like this are, of course, deeply unsettling, especially when they happen within our own facility. We see verbal and physical outbursts against our staff on an all too regular basis, including an incident just this week at CORE. No one should have to fear for their safety while doing their job. And at a time when many people may be experiencing additional stress and anxiety, we want to be sure that we have appropriate measures in place to ensure the well-being of our staff, our patients, and our visitors. Again, I want to celebrate our Provident team members who responded so swiftly to the incident. You are to be commended, and thank you to all for your unwavering commitment to our patients and to each other. Thanks again.
Thank you. Before we move on,
If I
before we
can,
move on, please, Director Ryder.
yeah, if I can, Eric,
Yeah.
you know, as many of us know, we all know people who work in the system, in addition to just sitting here, and we know doctors, nurses, PAs, people who work in our finance department, and I personally know people who work in the emergency department at Provident Hospital. So thank you to all of you who, showed up to, protect your coworkers, and also thank you to, Dr. Makaitis for responding quickly. Our hope is that we can do enough to make sure that we can mitigate any, you know, there's no system that is perfect, but we can do things to help support our folks. And you know, as my mother was an emergency room nurse for a large portion of her career, and just know that we understand the difficult jobs that people in the ED have, and that we're here to support you.
For sure. Thank you.
Commissioner Lowry.
Thank you, Chair. I just want to echo the comments of my colleague. I want to echo the words of Dr. Makaitis and say thank you for your outstanding response during this emergent situation. I also want to just say this is just another example of what makes Cook County Health, and specifically the team at Provident, so special. And Dr. Turner, I just want to shout you out publicly and say thank you for all that you do and all that our team does at Provident. Truly one of the gems of the 3rd District. And I want to leave you with this. Events like the one we're discussing gets coverage. What doesn't get coverage is some of the other just really important work which you are all doing. And I want to say thank you. I was doing a radio show in preparation for my men's health fair, annual men's health fair, during the fall of 2023. And the gentleman called in tears because he had not only a high PSA level, prostate-specific antigen test, but also had, based on an MRI, inflammation of his prostate, was scheduled for a biopsy, and then lost his job and his associated insurance. He called in, you could hear him crying, and he said, "What do I do now?" That afternoon, I put him in touch with Dr. Turner, and he called me about 2 months ago just to say that he had had treatment at Provident and was cancer-free. I think it's important for us to celebrate that. Thank you.
Director Vaughn.
Thank you, Mr. Chair. Just echoing the comments of my colleagues here on the board, and just to also commend the work of follow-up around an RCA, and thinking about this from a quality and patient safety angle. I just want to commend Provident for their work around quality and patient safety, as we've seen, the progress that the team has made there.
Thank you.
Okay, that concludes the first part of the report, Chair Taylor.
Thank you. We appreciate it. And again, I will close with thank you to all the team. And where it's appropriate, congratulations for the promotions, the recognitions, the honors. As you were going through all of these awards, I kept thinking, all I do is win, no matter what. So I think that should be our little tagline for CCH. All we do is win. The next item is public testimony. As a reminder, written testimony would not be read into the record, but will be included in the official record of this meeting and posted up to the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual oral or submitted written testimony?
We did not receive any registrations nor any written testimony.
Okay, thank you. Minutes of the January 24th board meeting are being presented for your approval. Are there any corrections or revisions needed to be made to the minutes? Will you look through any corrections or amendments? Okay. Hearing none. I'd like to entertain a motion to approve item 4A, the board meeting minutes of January 24th, 2025.
So moved. Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? You have a question?
No,
Okay.
Chair Taylor, I would like to be on record
Okay.
as voting present on request number 2 of the contract and procurement items contained within the Finance Committee meeting minutes.
So recorded.
Oh, I think that's for later on
That's
when
for
we do the
When it be
finance minutes. These are the board minutes. I know.
4 minutes. But we do know that you're going to be on record for that. Okay.
Gracias.
Okay. So moving forward, if there's no other discussion, all in favor?
Aye.
All opposed?
Aye.
Thank you. The ayes have it, the motion carries. Next, Director Harrington, will review the Audit and Compliance Committee meeting minutes.
Thank you, Chair Taylor. The Audit and Compliance Committee met on Friday, January 31st at 9 a.m. Our next regular meeting of the committee will be held on Friday, April 11th at 9 a.m. Nicole Amiro, Chief Corporate Compliance and Privacy Officer, reviewed the report, which included information on the following subjects: highlights of fiscal year 2024. Metrics include year-over-year comparison, contacts by category, subheadings, Cook County Health Systems Compliance Program, Cook County Care Compliance Program. We received and filed annual reports for Cook County Health and Cook County Care. And facing forward, we're going to be working on the fiscal year 2025 compliance work plan. The committee received and filed the FY 2024 annual reports for the Cook County Care Compliance Program and Cook County Health Provider Compliance Program. If there are no questions on the minutes, they are being presented for the board's consideration at this time. Any questions?
Hearing none, I'd like to entertain a motion to approve item 4B, the minutes of the meeting of the Audit and Compliance Committee of January 31st, 2025, containing the following action items: receiving and filing the County Care Compliance Program fiscal year 2024 annual report and the Cook County Health Provider Compliance Program fiscal year 2024 annual report.
So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
Aye.
All opposed? Hearing none, the ayes have it, the motion carries. Next, Vice Chair Lowry will review the Managed Care Committee meeting minutes.
Thank you, Director. The meeting of the Managed Care Committee of the Cook County Health Board of Directors was convened on January 31st, 2025. There was no public testimony, and the committee then received and filed a report on health plan services presented by Aaron Galiner, Dr. Yvonne Collins, and Christina Torino. The report included information addressing the following: health plan metrics, 2024 successes and year in review, 2025 strategic initiatives and priorities, which included strategic roadmap, member experience, quality, health equity, and talent and teams. The next meeting of the committee is scheduled on April 11th, 2025 at 10 a.m. And I now seek a motion approving the minutes of the Managed Care Committee meeting as previously noted, which took place on Friday, January 31st, 2025. Is there a motion?
So moved.
Second.
I have
I take the motion.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? I like all the initiatives. Any discussion? All right, hearing none. All in favor?
Aye.
All opposed? Thank you, Director Garza. All opposed? The ayes have it, the motion carries. We got our Robert's Rules of Order over here.
Thank you. I will try to leave downtown. I promise.
You'll know whenever you look over the writer, he'll tell you if you're doing it right. Next, Director Bott will review the Quality of Patient Safety Committee meeting minutes.
Thank you, Chair Taylor. The Quality and Patient Safety Committee met on Friday, February 21st at 9 a.m. The committee approved the following action items, which are included in the minutes. Approved 5 Stroger Hospital Division Chair initial appointments. Approved Stroger and Providence Hospital medical staff appointments, reappointments, changes. Committee received the following reports, which are included in the minutes. Operational Excellence Dashboard Goals and Tactics, Providence Hospital Site Review, Stroger Hospital Site Review, ACHN Site Review, and the Regulatory and Accreditation Update. The next meeting of the committee is Friday, March 14th at 9 a.m. And I just want to add a comment here is really grateful for the work of our teams on quality and patient safety, and good to see the progress in the committee meeting recently, and appreciate their hard work. So if there are no other questions on the minutes, they're being presented for the board's consideration at this time.
Are there any questions? Okay. Hearing none. I'd like to entertain a motion to approve item 4D, the minutes of the meeting of the Quality and Patient Safety Committee of February 21st, 2025, containing the following action items. Approval of 5 Stroger Division Chair initial appointments, and approval of the proposed Stroger Hospital and Providence Hospital medical staff appointments and reappointments and changes. Do we have a motion? So moved.
Second.
Thank you. Well, no, Director Garza seconded. The motion has been made and seconded. Is there any discussion on the motion? Hearing none, all in favor?
Aye.
Aye. All opposed? Hearing none, the ayes have it, the motion carries. Next, Director Ryder will review the Finance Committee meeting minutes.
Thank you, Mr. Chairman. The Finance Committee met on Friday, February 7th at 10 a.m. The next meeting of the committee will be held on Thursday, March 6th at 10 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved 12 contracts and procurement items. Number 10 is pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. Approved as amended 3 proposed resolutions authorizing signatory changes for Cook County Health Accounts held at Chase Bank. We received and filed grant award related items. The committee received the following reports, which are also included in the minutes. Our MBE WBE report of 1 emergency purchase, and report of December financials, and the monthly report on agency reduction plans. If there are no other questions, the minutes are being presented for the board's approval at this time.
Thank you. No question. I'd like to entertain a motion to approve item 4E, the February 7th, 2025 Finance Committee meeting minutes, which contain the following action items. Additional approval of contract and procurement items pending review by contract compliance. Approval of 3 proposed resolutions as amended authorizing signatory changes for CCH bank accounts held at Chase Bank, and for Oak Forest Health Center depository account, Stroger Hospital checking and or savings accounts, and Providence Hospital checking and or savings accounts, and receiving and filing of the grant award related items.
So moved.
Thank you. The motion has been made and seconded. Is there any discussion? Hold on, first,
Yes,
Director Robinson, I believe you have.
I do. I would like to be recorded as voting present on request number 2 of the contract and procurement items contained within the Financing Committee meeting minutes, please.
So noted. Thank you. Director Green.
Chair Taylor, please record me as voting present on items number 3 and 10 in the contract procurement from the finance. Present.
So noted. Any other questions? Thank you. The motion has been made and seconded. As I said, all discussion. All in favor?
Aye.
Aye. All opposed? The ayes have it. The motion carries with the correct notes in the record. We do not have any contracts being presented directly to the board for consideration, so we can move on to the next item, which is the proposed real estate related matter, which will be presented Where's Craig? There he is. By Craig Williams. Thank you, Craig.
Good morning, Craig Williams, Chief Administrative Officer for Operations and Development. Before you today, I have a proposal, and this is related to the transition of our research from Hectone to CCH. So currently, we have a Ryan White grant for HIV services that we lease space at the Austin Health Center under Westside Health Authority. We have 1,170 square feet that hosts our HIV team at Austin. That's currently leased to Hectone, as the grant currently is administered by Hectone. As of tomorrow, that grant will move over to CCH, and so we are actually taking on that lease space under CCH to align with the funding. We currently lease 13,790 square feet from the Westside Health Authority, and this would be an addition of 1,170 square feet. We also were able to obtain some tenant improvement dollars related to this addition.
Thank you. Any questions? Director? Thank you. Thank you very much, Craig.
Thank you.
I'd like to entertain a motion to approve the request to amend the lease agreement between the Westside Health Authority and the County of Cook to add 1,170 rentable square feet to the existing 13,790 rentable square feet in the building located at 4800 West Chicago Avenue in Chicago, Illinois, commonly known as the Austin Wellness Center.
So moved.
I'll make the motion.
Second.
All right, Director Garza, perfect. And then Director Harrington. The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? Hearing none, the ayes have it, the motion carries. We've already covered my report at the beginning of this meeting, so we can move to the CEO report, which will be reviewed by Dr. Eric Makaitis and a number of his staff. So settle in.
We'll try to be as efficient as possible. Thank you, Chair Taylor. Good morning again. We have several things on the agenda for you today. We are going to start with the high reliability reports and updates from Raji Thomas and Steve Kreiser. And then we will hand it over to Andrea Gibson for strategic planning updates. This will be a monthly topic for the next few months as we prepare for the next 3-year strategic plan. Andrea will introduce, and then we'll have a managed care scan, behavioral health strategy update, and 2 service line updates, one from cardiology and one from maternal and child. And I know we have a CCDPH report, which I believe we're going to receive as informational and just receive and file.
Okay, thank you. Andrea just left. Oh.
Take it away, Steve.
I'm not sure. Sure, that means.
Well, good morning, everybody. Thanks for having me back. It's great to
morning,
see you. And again, thank you for your leadership of this culture of safety and reliability. I enjoyed hearing a number of the reports. I wanted to give just a little bit of an overview again of what we've been doing, what we've been talking about, but really then segue into your role in terms of board governance and really leaders of this in so many ways. So we've talked about these 5 principles of high reliability. Really, White and Sutcliffe in their book described them as the 5 principles of organizational mindfulness. I've always loved that term mindfulness because I think of it as the opposite. The opposite of mindfulness is mindlessness. I think we would all agree we don't want mindless people, taking care of our patients, taking care of us and our loved ones if we're in a healthcare situation. We want mindful people who are really looking out for what can go wrong, the little things before they become big things. They're very proactive and preemptive in how they analyze and discuss those things. That's a preoccupation with failure. They're very sensitive to operations. They're getting to the front line where the work is being done to understand the complexities, the high-risk nature of the work. What are things we haven't done in a while? Where do we not have all the resources we would love to have? And how do we move those resources and people, when and where needed? That's that sensitivity to operations. Reluctance to simplify interpretations means we don't take the easiest answer. We're always being skeptical and questioning what's going on in our system and in our people, which is the most important part of the system. So we encourage people to have a diversity of thought and to question things and to question the answers. to voice concerns, to speak up, and that means we have to have a good culture of psychological safety and comfort, in that, to approach people, that even if we perceive them as being higher in authority or power, we still are encouraged to do so. Now, sometimes, despite our best efforts to stay out of trouble by anticipating failure, we sometimes will have something go wrong. In any complex organization, despite our best efforts, people are people first, and either novice or expert second. And systems that are complex will sometimes fail, but we shouldn't let it get out of control. We need to be able to contain it, to keep it from getting bigger than it has to be. And so we have these different mechanisms and barriers we put in place to be resilient, to learn from errors and mistakes before they become something that is repeated down the line. And the deference to expertise is about the power of teamwork. Let's push the decision-making and empower people to do it the most, to take action, to make decisions, to keep an error at a small level, to become bigger than it has to be, because we say it's okay if you just speak up. If you're the expert in maintaining the counts in the OR and you say the counts are off, we're going to stop, and we're going to say we're not going to move forward until you say it's safe to do so. So 5 great principles. On the next slide, it's about taking these and creating a high reliability operating system, if you will. Next slide. High reliability is all about improving our people and the processes, and it's about how humans interact with the system. There's a lot of elements that go on into it, as you see here. One of the key ones is how we message safety first throughout the organization. People take their cues from all of us as leaders. We used to have a saying in the Navy, what my boss finds interesting, I should find fascinating. And so what are we demonstrating to our people, what we find interesting in our organization? I was sitting outside as we started the meeting, and I know there's a lot of structure that goes in here between the stuff we can have public and the stuff private, but I really encourage you as board members, if we say we want safety first and it's the most important thing, to us and our people, let's start our board meetings with safety first on our agenda. Maybe a great catch story, maybe a discussion on days since our last serious safety event. There's a lot of things you can do. This is what we're encouraging leaders throughout the organization to do. If we have a written agenda, or if we have, a standing meeting, even without a written agenda, let's always start it with a brief, literally 2-minute or less safety moment, or something that sort of makes us all remember, despite our busy day and all the different financial and operational issues we have, we're always going to be grounded in the idea of safety first. That's a great way to message, in addition to a number of other things, our commitment. We got to have structured leadership. Think of leader standard work. We call these high reliability leader skills. I'm just going to show you a few of those we've been talking about. You have to have good, rigorous event causal analysis. It's good hearing, how you're doing that, and how you're approaching that with good, strong corrective actions that we monitor for effectiveness and ensure that are sustained. But we've got to also now have some strategies to reduce human error. We just can't focus on the system because people are the most important part of any complex system. So what are we doing to make our people less error prone? I'm just going to give you a couple examples here in a moment. Of course, we always have to work in good process and performance improvement. And then that last bullet, so critical, I mentioned it earlier, psychological safety and a fair and just culture. Next slide. I want to go through just a few slides on psychological safety. Many folks have heard about it. The key thing I want to point out is you can't learn it in a classroom. It's not like you can go through a 1-hour class on psychological safety and suddenly everybody's going to feel it here across the organization. You see some things here that Amy Edmondson talks about up in Boston. She's an expert in the subject. People don't want to look ignorant. So what's the natural response mechanism? Don't ask questions. Folks don't want to come across as incompetent, so they're not going to admit weakness, meaning I've made a mistake or an error. They don't want to be intrusive, so a lot of times they're going to maybe not voice concerns or point out somebody else's error to feel like they're putting somebody in the defensive, and they don't want to be looked at as the negative, Nelly in the organizations. Apologize to anybody named Nelly, but they're not going to then maybe criticize the status quo, okay? And what this does is it robs us collectively as an organization of those opportunities to learn and improve. So it's really essential for leadership to foster this environment that creates a productive discussion, earlier detection of problems and issues. You have to build it into the structure. It's why our huddles are so important at all levels. It's why it's important that we're out rounding as leaders, creating that comfort level, asking questions, and not having people feel like they need to run away, but they run too, to understand that it's okay if they don't know, but we want to have the conversation so that they do know, the expectations and how we do things and sort of where that line is that we're trying to draw between acceptable and unacceptable behavior. We want to build trust. you know, a trust in leadership. Psychological safety comes from that trust. Next slide. Now, sometimes folks are hesitant because of these perceptions of hierarchy. Gert Hofstede, a Dutch researcher, calls it power distance, which is sometimes the extent to which the less powerful expect and accept that power is distributed unequally in a culture or in an organization. He studied around the world and found it was quite high in certain areas of the world, generally Singapore, you know, Asia, a lot of countries where they grow up, you don't question authority or, you know, point out somebody's mistake or error based on maybe race or gender or age, right? You see it sometimes in some of the South American countries. You see it in the U.S. Sometimes, you know, in different subcultures. We had it in aviation. There's a problem with the co-pilots being afraid to speak up to the captains. And it was found to be the primary causal factor in a lot of tragic accidents back in the 70s and 80s until that industry started to get their hands around it. We see it in healthcare sometimes between nurses and physicians, maybe residents and attendings, sometimes non-clinicians to clinicians. And even though you may not have somebody who's authoritative and hierarchical saying my way or the highway, it could be the nicest person at the top of that authority gradient we see in the bottom right of the slide, but people perceive. Who am I to say something to the physician? I'm sure they know what they're doing. They must have thought this through. Or who am I to say something to that nurse? They're a clinician, I'm just somebody at EVS. And we have these outward signs that sometimes contribute to that based on the number of initials behind our name, right? Or the amount of time we've been in the organization, the amount of classes and schooling we've undertaken, sometimes the little perks that come with the job. I'm not saying take those away, but what I'm saying is you need to be aware of them. Because if we want people to be reluctant to simplify, to speak up, identify these errors, these issues in our system, we, especially those of us that we think of as being the top of the spectrum, need to take active measures to try to flatten that hierarchy. And it needs to happen almost each and every day, right? Next slide. Now we have here a number of things to help, and we've been sort of talking about a lot of these things, and I want to talk about the first two, if you'll hit the button again. You know, these ideas of how we message safety first and make culture come alive, zero harm. If you could hit the button again, I want to focus on those first two items. And on the left side of the screen here, we see some things that are important on leader messaging, starting our meeting with safety. I just mentioned that. Thanking those who speak up. You know, whenever possible, getting out to the environment and doing it publicly and personally. That goes a long way. It doesn't affect that individual. People take notice. It starts to spread. You know, when someone maybe spoke up or noticed something that wasn't quite right, and then they're thanked, it's reinforced. Now that goes a long way to improving our culture and creating safety. Talking about safety in our decisions. You make a lot of decisions here as board members. Wouldn't it be nice, or isn't it nice when somebody says, hey, how's that going to affect the safety and quality of our care? Right, almost as a field agent that's there as our collective consciousness. You know, that's always nice, and be able to then talk about that when we're out, you know, with the front line. There's other things in this list that we're discussing with your leadership team to create this high reliability operating system is a good way to think about it. Because we have to put some things in place in any HRO to create structure that can be handed off from one generation of leaders to the next. If you want something sustainable, it's not just a flavor of the month that's built on feelings, but that's built on structure. We want to, you know, not be micromanaging in our work, but maybe be thorough in how we oversee the work. My old commanding officer used to say, Steve, there's a fine line between micromanagement and thorough oversight. And so these different elements are meant to be maybe more thorough in terms of what we put in place to define how we do our huddles, how we want folks to get out and around, how we want to have different ways to learn from errors and mistakes through our cause analysis and local learning programs, PI activities, how we're going to go ahead and make sure we're consistent in our application of fair and just culture. What this does is it gives us a way as leaders to create the conditions for culture to grow. You saw on the previous slide the sub-quote that says, you know, be a farmer of culture. You know, when you think of farmers, farmers don't make crops grow. Farmers create the conditions for crops to grow and how they maintain the soil, the nutrients, fertilization, irrigation, rotating the crops. We need to think of our role as leaders as creating the conditions for culture to grow. On the next slide, you know, we have some more thoughts on this, some things that we need to, you know, keep in mind in terms of messaging. These are some examples from organizations, your peers around the country. We've got hundreds, if not thousands, of these ways that organizations are making culture come alive. Now, I have to be honest, in the past, I haven't seen as much of this as I'd like to see at Cook County. You know, we want to make culture come alive through the visual mechanisms, and we've been working with your marketing communication folks. Dr. Makaitis is really committed to making this more visible, so I hope to see a lot more of this in the near future. Slogans, logos, mottos, talking points. In a minute, I'll show you how we have these toolkits. They're very important to come alive to our people in the sharp end. Having things on the walls, on the elevator doors. I said hangar doors because we used to have things, you know, in my previous life as a naval aviator that made us really clear it was safety first in all we did, despite the fact we had an important mission to do. If we couldn't do it safely, we weren't going to do it, and yet we're going to do that mission. Next slide. I want to talk about these middle two things here about giving people tools to speak up and the importance of preventing error, thinking of an error prevention toolkit, if you will. Next slide. You'll see an example of this. In fact, this is your example. And when if I were to show you some other organizations, this will be very visual and almost pretty, eye appealing. It sticks out. All we have here is like a two-sided table. So we're working again, and it's on our list to make this a lot more visual because these are very important tools to help our people prevent human error, to be more comfortable in speaking up, paying attention, and communicating. I want to point out to an august group like this, these are evidence-based. There have been studies and research to show how they cut down on the different sources of human error. Next slide. You know, humans are humans, and we're going to make errors from time to time. We've been training your people on this, and we want them to go train the front line. When we've done something a lot in a very familiar situation, almost routine, we do it in what's called skill-based performance. It's like being an autopilot. You'll see this when you drive to work. How many of you drive to work every morning, you get to your parking spot, and you have no idea how you got there? Welcome to skill-based performance. You don't make a lot of errors, but occasionally you'll get to your parking spot and you forgot your badge card at home. Or maybe you locked the keys in the car. That's called a skill-based error. They happen about 1 out of 1,000 times, but we do so many things in skill-based mode every day, we can sometimes make 10 to 30 errors a day. You go into the wrong patient room, you open the wrong patient record, you're looking at this record, you go to diagnose that patient, you're in EVS doing all these cleaning activities, you think you're in a C diff room that demands a certain type of cleaning protocol, but actually it's the room that had MRSA, and maybe that's a little bit different. Now, if you haven't built something as a skill, we have to think. It's called rule-based performance. We go and recall stored knowledge in the form of rules. If I see a situation demands a choice, you pull that rule from long-term memory to short-term memory in 600 milliseconds. It happens so fast, you don't even know you're doing it, but then as experts, we make that decision. Usually it's the right one, we move forward. But then sometimes we'll use the wrong rule, or maybe some type of pattern bias or something influences our thinking, right? And we make a critical thinking error. Or maybe sometimes we know the rule, we think about it, but we may make a choice to circumvent or do the workaround. Why is that? Is it because we want to harm a patient or a fellow employee? Very rarely would anybody want to do that. They'll do it because of a perception of a production pressure that is overwhelming a protection mindset. And so what do we do to our folks? Maybe there's an extreme burden to comply. And so that individual does the workaround, it works okay today, and we almost feel self-satisfied. So we're going to keep doing that, and maybe we'll actually give that as a practice tip to some of our colleagues. Now they start doing the workaround to make their day work better, and it's going fine until one day all the holes line up and it results in a tragic event of harm. That's called normalized deviance, when everybody is not complying together. And you got to watch out for it before it finds you, especially as a leader. Sometimes you go to find the rule, it's not there. That's called knowledge-based or lack of knowledge. You've never done it before, and that's very dangerous because the error rates skyrocket. Look how they jump up to 50 to 60%. And so in a high reliability organization, they say, if you're not sure, stop. Stop in the face of uncertainty. This is where the Toyota production system years ago came up with the stop the line concept. Pull the chain. And they had to really focus on encouraging people that was okay. We'll take the hit on volume production today to identify the safety or quality issue, get it fixed, and be safer in the long run. It's not human nature, to do that unless it's highly encouraged throughout the organization. I have just a couple of examples of these, and then I'll wrap up. If we go to the next slide, please. Some examples of these rule-based, this is a skill-based exercise. I want you all to say these words, even the folks in the back, left to right. Say the word with me. I want to clap to keep us on a good cadence. Are we all ready? Let's go. Red, blue, green, black, yellow, green, red, pink, black, brown, yellow, gray. Okay, sort of haphazard participation. So we did pretty good. That's skill-based. You know, reading is a skill-based type of activity. We can read the words left to right pretty fast, pretty accurate. I'm going to clap at the same cadence now, and I want you to say the color of the word. I'll even give you some time to practice. The color of that first word is what? Green. The color of the second word is red, and then it's, let's call it yellow, green, and blue. Are you ready? And 3, 2, 1. Green, red, yellow, green, blue, black, green. Started out pretty good. We had a few folks. Some folks don't like to participate, but you could hear immediately the sort of wheels came off. We had to have considerable effort to overcome that sort of skill-based tendency that we can get into. But there's so much power in this one technique we teach people when you're in sort of this autopilot mode. Stop and think just for a second or two. It came out of the nuclear power industry to keep the plant operators from turning the wrong knob, button, or switch. Some of that was what led to the 3 Mile Island event, when they didn't have a valve closed properly in one of the reactors. So let's all take a pause of 1 to 2 seconds before each word and see how much better we could do. And you're all urgency addicted as healthcare professionals, so I'm going to really force you to slow down. I'm going to say the word pause. Are you ready? And 3, pause, 2, pause, 1, pause, go. Green, pause. 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 There you go. We could do the whole thing and you'd be highly accurate with just a 1 to 2 second pause. Now the lesson here is don't let people tell you we don't have time for the safety stuff. We're busy. You know, we got a lot on our plate. Patients are counting on us. There's always time for a 1 to 2 second pause when going from thought to action. We got to teach our people this idea of self-checking. It's called self-checking using STAR. But it only works if the leaders are promoting it and talking about it on a regular basis. Next slide, we have some examples of these rule-based errors. Good question for the crowd. Does Mr. Monopoly wear a monocle?
Yes.
No, in fact, he does not. Mr. Peanut wears a monocle. Mr. Monopoly does not. You can look it up. Is there a peanut butter brand called Jiffy?
Absolutely.
No, it's called Jiffy.
Yes.
See, we learn these rules, and they're called wrong but strong. What's the famous line from The Empire Strikes Back when Darth Vader reveals his identity to Luke? I am your father. No, that's not it. He actually says, no, I am your father. Not Luke, I am your father, but no, I'm your father. What does the wicked queen say in Snow White when she talks to her mirror for advice? Yes, no, it's not mirror, mirror on the wall. It's magic mirror on the wall. So we get these different things in our heads. Let's go to the next slide. I'm sorry, I had these animated, but I think we're now in PDF mode. So you've given away my answers. Anybody like Fruit Loops as a kid? Do your kids eat Fruit Loops? Normally, you just see the box on the left, and then I'd animate to see the box on the right. You did not ever eat Fruit Loops with a U-I-T. You ate Fruit Loops with an O-O-T. When I saw this, could not believe it. I had to go look it up online and go buy a box of Fruit Loops because it actually has always been spelled fruit with double O. See, we learn these rules, and then when our people sometimes are making mistakes because maybe they learned the wrong way or they have this wrong but strong way of doing things, we want to maybe jump right to the conclusion of, how did they not know rather than why did they not know.
So this is a great presentation for the staff. I know that we have a lot of time issues, so I'm just wondering, because we're the audience. So
and you don't get a lot of time for this. We actually covered some of this in our last high reliability session with your leadership team.
That's awesome.
Across the organization, and we're telling them, you need to get out and talk to your staff about this. Maybe next year we'll actually do some train-the-trainer work if we want, or there's other mechanisms, but I'm really confident your leadership team has embraced this. I just don't know how much they're actually, anything you go through training, you got to then get out and do.
Yeah.
It's got to be sort of something you build as a habit to understand this. Because all these, next slide, these are the why behind the what. These are why we had those tools you saw on that two-sided table. One of the tools in that table, in addition to the STAR technique, is the idea of peer checking, which means I'll check you and point out if you make a mistake or an error. And please, care enough about me to point out if I make a mistake or error as well before it harms a patient. If we don't have that kind of a culture where we care about each other enough to speak up, and people aren't going to speak up. They're not going to check you. Hey, you forgot to wash your hands. Don't forget to gown and glove. I don't think everybody was really paying attention during that timeout. You know, they were distracted, or we rushed through it, let's do it again. We all make errors, sometimes one out of 1,000 times, but if I'm committed to good cross-checking or peer checking, the one time you make an error, I'm there and I point it out, and you say thanks, and the one time I make an error, I say, hey, thanks, and you know, we don't make the error together. Really, you cross-multiply those error rates. So if we're doing this good job of peer checking all the time, we go to high levels of reliability, like 1 in a million we can make that error. But there's a lot of ifs there. If I'm willing to speak up, if I view you as receptive, and the whole 9 yards, it gets back to cultural. Next slide. Now, sometimes people will be defensive, and they'll say, hey, mind your own business. You know, what should our people do when they try to speak up and point out an error, and someone tells them, mind your own business, especially someone at the higher level of that power distance, you know, gradient? What do you think? Do they still have an obligation to speak up? Should they try again? We think yes. You know, that's what this whole thing was in aviation. You know, sometimes the co-pilots try to speak up to the captain, but the captain was God. You know, you didn't cross them. And in Korea, they had a really strong culture. There were stories about the captain slapping the co-pilots that had tried to speak up or point out their error. Can you imagine that? Is anybody ever going to speak up if they're slapped, physically slapped? And we may not have physical slapping in our organization, but we sometimes have like verbal slapping. You know, maybe inappropriate responses, maybe eye language or body language. That's all cultural. So we have this technique that came out of that commercial aviation industry. When someone first asks a question or tries to peer check someone, and it gets a poor response, you need to ask again. Maybe reshape it as a request, or just say it a different way. And if that's still, you know, not working, you need to have safety phrases. The safety phrase here, I have a concern, is meant to make the hair on the back of people's necks stand up when you hear it. Let's protect that as a safety code or phrase. These other industries all have these phrases, like stop the line, you know, like I mentioned before. We had them in my naval career. Someone's telling you, if you don't change your behavior, Steve, you're going to fly in the water and kill yourself or somebody close by. So anyway, that's an important tool in our toolkit that we're talking about, but it only works if people are paying attention and listening, and then, you know, integrating into their language. Next slide. Just a few more left here, because I wanted to talk about those ones on the far right, you know, to help our culture grow. Next slide. You know, what leaders do. All about leadership. So this is like a version of a leadership toolkit we saw earlier, but what are we doing through our huddle to maintain that constant awareness of what's going on at the front line, that sensitivity to operations? So that's all about huddles and anticipating events. The third column, how do we learn? Through our cause analysis efforts, learning at the front line. And then the right side, a whole idea of accountability. Such an important word. And not forcing people into accountability, but making them intrinsically want to do it because it's their idea. It's the right thing to do. And that happens because we're out reinforcing. We're giving them positive feedback when we see them doing the right thing. Corrective feedback when they're not. The ratio should be 5 times as much over the course of a week or a month. We should be giving people positive reinforcing feedback as when we sometimes have to give corrective. The rounding principles, the fair and just, it all goes into that category. Next slide. I want to point out there's still all the work in what I call the verticals. We're never going to stop with our efforts to improve processes, and the list could go on and on, as you see there, and a lot of these things I've heard you talk about in these meetings and others. But this focus on safety and reliability culture is cross-cutting. We develop a great process. Now, if we have people that are paying attention, focusing on what they're doing, not afraid to speak up and point out to others, bring up problems and issues in their huddles, that makes all those vertical efforts work better, and it makes them last longer. So on the last slide here, I'll finish, and I had a version of this previously, but your role as board members. You got to maintain constancy of purpose and a relentless drumbeat. You know, even through the good times and bad, you know, making sure we are explicit. I've never met a leader who says they want to be unsafe or unreliable. Does anybody want to raise their hand to that question? It sounds ridiculous. But it's what you're seeing, not just saying or believing in, but doing. And that's why I mentioned small things like starting meetings with safety and, normalizing the discussion of harm, being transparent about it. Not to put ourselves at risk from a legal or claim standpoint, but maybe talking about data, talking about things in aggregate, de-identified discussions, right? Making sure we align our incentives and compensation around a focus on safety and quality. Always safety first in decisions, and make sure we're devoting time to include that when we're talking about capital expenditures or changes in processes or other discussions. make sure we're focused on systems, processes, and structures, not, maybe just finger pointing or blame. These are three great questions for you to ask the executive team, the management team, the organization as a whole. Are our leaders out at the sharp end rounding on a regular basis? And how do we know? What are they talking about? What are some ways we can maybe measure that? Okay? They're looking to you to see what you find interesting for them to find fascinating. Every leader in an organization should commit to getting to where the work is being done and talking about expectations and seeing where the barriers are for people to be successful. Are our huddles effective? I've seen good huddles and bad huddles over the years, and there's some indicators of each. Do we have good senior leadership? Are people encouraged to report? Do we have items for follow-up? Are folks fully engaged, or do they just come in with a lot of no issues, nothing to report, because they haven't gotten to their work areas, beforehand? They're not comfortable coming and talking about where they've had failures or issues in front of their boss or in front of their fellow leaders. And these are the kind of questions we're asking and coaching them on. I need you as the board to also be asking those questions on a regular basis. How about our staff and our physicians, our people at the front line? Do they know those tools I just went over very briefly? If they don't know them, if they can't talk about them or share a story where they prevented harm, then they're probably never doing them. So why even go through the exercise of having training or discussing them? How do you measure that? There are some mechanisms to do so. That idea of metrics so important in healthcare. What measured is what gets improved. And there's different metrics there that you can see, and there's process metrics as well. So thank you so much for your time. I hope I wasn't preachy. My wife, who's a nurse, calls me Safety Steve, and I think you can hear my passion. I want you all to be just as passionate, and hopefully I gave you some good things to think about on what you can do, because what we do as leaders, is what matters. Thanks.
Thank you.
Thank you.
Are there any questions, by the way?
I think it'd be appropriate for the Army to have a conversation here, since you had to bring the Navy in.
I love it. Love it.
But what we would call what you're talking about would be good training. And that's where these things get enacted.
100%.
And it actually starts at the sea level, and then it works its way down. Because at that point, now you can actually have the freedom to challenge the wrong action, because it's not personal. It's about the end result. That's what you're speaking to. And I think we all support that.
100%. Thank you for your service. And, I love the Army's take on things, because training is about building good habits. And in a time of crisis, people say you rise the occasion. The Navy SEALs say you don't rise the occasion in time of crisis. You fall or sink to the level of your training. And so that's got to be, good habits that are formed in our training, and it's got to be constantly, something leaders are paying attention to. Well said.
I have a question.
Yes.
So you mentioned, skill-based performance versus, role-based performance.
That's correct.
It sounded to me, skill-based performance is actually a better way to do things, because you.
So, the error rate is lower in skill-based, because it's where experts operate. You've done it so much, you can do it without thinking almost, driving your car, flying an F-18, landing a carrier, daytime at certain points in your career, you would almost do it sometimes without thinking. But we recognize we do so many things in skill-based performance, and we still will make errors from time to time, usually when we're interrupted, distracted, multitasking, fatigue, which is why pilots started to come up with checklists. Let's make sure when I'm in autopilot, I don't forget to put my landing gear down or my tail hook to catch the wire on the ship. In healthcare, that's why we have things like double check name and date of birth. Because we can go into so many rooms, or we're doing so many surgical procedures, we still have to stop and think for a second or two. Do I have the right patient? Let's verify these certain things so we don't experience a skill-based error.
Right, so, but when you think about patient safety in the hospital setting, we're thinking more of like guidelines, procedures, checkpoints, like things that are rule-based, right? So is it a goal, like actually train people to move more towards skill-based?
These are very dynamic modes, and you'll be fluctuating them from hour to hour, minute by minute. It's a good thing for people to have done something so much that they can do it, on this sort of almost without thinking. Malcolm Gladwell in his book Outliers talked about it takes 10,000, times practicing or training something for it to become something you can just do without thinking. It's how Steph Curry got to be the best three-point shooter in the NBA, or Wayne Gretzky became the leading, shooter in hockey. So we want to get them. I talk to surgeons who will talk about they've done it so many times. Sometimes their hands are doing stuff before their heads are engaged. it's a good mode, but occasionally if we're not careful, and usually, again, it's when we get interrupted or distracted while we're in skill-based, or maybe we're fatigued, or multitasking is a very dangerous mode. It's actually a myth. We all think we're great multitaskers. You know, if any of you were on your phone when I'm talking and I suddenly said, hey, what do you think about that concept? I don't know this gentleman's name over here. What did I just say? I'm sorry to call you out. We're not great multitaskers. We think we are, but we're actually sequential taskers, and we'll go back and forth between things in rapid fashion. And then sometimes the things become too much for our minds to be able to bear, and then like the balls will come tumbling down. And this is very dangerous. Why texting while driving is discussed as a very dangerous behavior. And we need to be really on the lookout for that, because we may think we're great about it until one day we're heads down and we drift off the road just a little bit. And that one day we drift off the road a little bit, there happens to be a bicyclist there in the shoulder, and we run into them, and lives are changed forever. In the same way in our organization, skill-based is a good mode to get into, you know, normally, but we have to be on the lookout if we are trying to either do things, you know, too fast, or, you know, in too much of a rush, or we're cutting corners, you know, those kind of things, you know. But don't get me wrong, they're both, you know, appropriate modes. Rule-based performance is where experts operate, and so they've done it so much they can do it in sort of that skill-based mode.
Thank you.
Yeah, the last two big bullet points focus on systems, processes, and structures, monitor metrics. That seems to be primarily patient care focused, but we also have a public health department, and we operate the largest Medicaid managed care program. So is this focus really on the hospital or the entire system?
Entire system. In your outpatient areas, there are metrics of safety and quality we'd like you to measure there. We want to think about workforce safety. Do any of you know when the last, you know, serious employee injury was across the organization, or at least in your facility? Weeks ago. Weeks ago. That's great. Yeah. I mean, that's like what you'll see in industry. The CEO of Alcoa will know exactly when the last, you know, serious injury was to an employee, and that sends important messages to the employees, and they know they care enough to at least know when there was a harm event, and now what we're doing to help them out. Great questions, by the way. There was one other one, I think, as you were, was you, Eric, you were about to ask something? No. All right.
And that's why Roger's gonna do the Six Sigma, because that'll help us get there.
The whole lean, you saw my couple slides about PI, process improvement, Lean Six Sigma being one of different approaches to PI. It's incredibly important. It goes hand in hand with, it's part of an HRO organization.
Thank you.
Thank you.
Director Bob, we look forward to these updates in the safety committee, in the QPS committee.
Oh, I bring up HRO and Safety Committee.
Yeah, we look forward to it going forward.
We'll bring it forward.
All right, Andrea. I think maybe let's just receive and file the ARPA progress, and we'll go into strategy.
Thank you.
Don't worry, Andrea, I'm not gonna text during your report.
I have your undivided attention.
He's gonna text you.
For today's strategic planning update, we have a number of presentations, and I'll be joined by several different leaders to talk about an environmental scan of Medicaid, of managed care. Also, Dr. Nutter will present the behavioral health regional strategic plan that they've been working on. And we have two service line updates, one from cardiology and one from maternal child health. So they are going to go over what has been accomplished, what is planned, what is budgeted, and what we may be evaluating for the future. And we are compelled to point out at that point that, you know, we know there's a lot of external factors at the federal and state level that will influence the timing of when we're able to expand or grow or change what we provide, but we still want to, you know, shine a light on these service lines as areas that we think we need to continue to invest in. Next month, we'll also have, neuro and cancer care present those service lines as well. So with that, we'll start with Aaron Gleaner on Medicaid managed care.
Thanks, Andrea. Good morning, directors.
Morning.
I'm condensing a Medicaid managed care scan into about 10 slides. So we'll move kind of quickly through this, but obviously please let me know if any questions. So the two kind of goals of what I'm presenting is a brief overview on county care and health plan services, and then talk a little bit about some of the local and federal trends in Medicaid managed care. So in terms of health plan services overview, just to give you some quick facts about us. So obviously our service area is Cook County. We've got about 34% of the Medicaid market share in Cook County. We're greater than 413,000 members. We have a very large network of providers. We have a 4-star quality rating, which puts us in the top 20% of Medicaid plans on a quality scale nationally. And we serve a broad variety of populations. A significant portion of our population is children and families. We also serve the Affordable Care Act adults, and have some of the largest share of Affordable Care Act adults across the MCOs. We also have an integrated care program, which is individuals that are older adults and persons with disabilities. We also provide services to individuals that have Medicare as their primary coverage, Medicare fee-for-service, and then we provide additional long-term services and supports on the Medicaid side, supporting those individuals. Then we also have a population of special needs children, and we also serve the health benefit for immigrant adult and seniors population. So there's a broad spectrum of members and different needs that they have within our plan. Next slide. Gives you a sense of demographics, and sorry for the font being a little bit small there. But you can see that about half of our plan is children and half adults. So that under 18, under 19 population is a really significant portion of what we serve. We're just slightly more female than male in the plan, and serve a large proportion of underserved populations across the county.
Eric, do you know in the 0 to 19 with the distribution of your children? I would have the same question. You don't have to do this one. A little bit more breakdown of the differences.
Yeah, we can definitely provide a deeper breakdown there. I think across children, it's fairly evenly spread. Adults has varied with the increase in membership we saw during COVID and now some of the decrease. So that's the adult population is a little more weighted towards 40 and older than 20 to 40. Okay. The next slide shows some disease prevalence information across our health plan. So top box there or table there is top disease states, the number of members by those disease states. So hypertension is leading the way, COPD, asthma, diabetes, behavioral health, and HIV. And then we also provide some of that breakdown by age category as well. So you can see in the pediatric population, for example, asthma is our largest disease state there, and then the hypertension and the adult populations, and of course that varies by age as you increase across the age bands. And this actually gives you some of that breakdown of the age detail as well.
So as far as coronary artery disease fall into the hypertension category, or does it show up in that category?
Yeah, some of that rolls up into the hypertension category, but there's we can also provide a further breakdown of some of those other disease states.
And many of the patients that have hypertension probably have some of these other conditions as well, multiple conditions. Do we know how many have? I would assume most have multiple conditions.
Yeah, many have multiple comorbidities. This rolls up, I think, mainly by primary diagnosis that we've received for the individual. So we can provide how many have co-diagnoses across these categories.
I don't know if we could look at it, but it's helpful to know how many people have multiple illnesses and multiple conditions, and what we're trying to do to, because it gets to be rough to manage a patient that has 3 or 4.
And you can definitely see that by the age categories as well. So particularly as you start to get over the 50 and older, you can see across the population that, there's significant increases across multiple disease states.
And to Director Harrington's point to build on, it's also I think thinking about the relationship between mental health and the chronic conditions, harder to manage those if you're not managing the mental health piece too.
Next slide shows,
It's just here, I did the math with those primary diagnoses, that's like less than 50%, so I guess if there's sub 1% that are longer.
yeah. So this just gives a quick snapshot of kind of where we've been, where we are today. So you can see the plan's had significant growth over time. So we're up almost 100,000 members since 2020. We've grown in quality ratings. Our total revenue is almost doubled, and also the size of our team, which we've been building over the past 5 years, is also more than doubled. So a lot of growth over time. I think, I'm particularly proud that we've been able to also increase quality during that period of significant growth. And that's really become a foundational aspect of what we're trying to lead the way on as a plan.
Aaron, question. When we look back on the previous page, if we look at the behavioral health, those are diagnosed cases, correct?
Correct.
Which we know that's like the tip of the iceberg. And I think that's worthy of notating, given our current structure in the United States, actually globally.
Yep, absolutely.
Yeah, I mean, I think that's the primary diagnosis of behavioral health issues, and we also have other secondary diagnoses, right?
Correct. All right, jumping forward a couple slides. So switching gears into some of the overall market trends. So again, this shows the Medicaid market in Cook County. So again, we're at 34.4% of the total market share. Blue Cross is second place there at 27.6. There's 6 core health plans. Meridian also provides services to what's called the youth care population. On the right, you can see county care utilization at CCH facilities. You can see we've had kind of incremental growth in that utilization over time, which has been a goal of ours. And we're also heading into, I would say, in terms of market share, into an RFP cycle with the state this year. So a period of some uncertainty there as some of these health plans may continue on, or we may see new entrants into the market. The next slide shows Medicaid enrollment across these different populations over time. So you can see we've had shifts in the demographics of our population over these past 5 years, particularly in kind of the proportions within our plan. So we've become a little more heavily weighted towards children. We've had some movement in how many seniors are being served there. And the ACA population is another one that we've also seen some overall decreases on over time from 23 to 24, and that's particularly because of the redetermination impact that we've seen. Next slide shows what the overall trend is. So we're currently in a shrinking market environment. So on the right-hand side, you can see the Cook County Medicaid overall. So our population in Medicaid in Cook County has been decreasing over time pretty significantly during redetermination, but you can see even in the past 4 months or so, which is past the big wave of redetermination for the first time since the pandemic, the market overall is still continuing to shrink in terms of the number of enrollees. But we are still seeing some decreases there. Our membership on the left-hand side has been a little more flat over that same past 3 months or so. So we've grown a bit in market share during that time, but we're still operating in this environment where there's less just Medicaid enrollees overall.
So, you may not know this right now, but is any of it attributable to people obtaining, private health insurance, or is most of the conversion going to, and is there an uptick in that? So people that are migrating, or is it what's the just complete drop off of people, just not accessing healthcare coming out of the pandemic? They're having, they're not taking the for it, or they're, even though they probably have.
Yeah, I think there's definitely both. Certainly over the course of 2024, there was quite a bit of shift, I think, between individuals that may have been on Medicaid that were working age population and may have shifted now to private insurance or onto the exchange. I think the other dynamic that isn't here in this data yet, but that we're concerned about is individuals who may qualify for Medicaid, especially children in the immigrant population, where the children qualify for Medicaid, but there's a concern about continuing to access or sign up for those benefits in the current environment. So I think, again, that's not something that's necessarily represented in this data here yet, since this is still 2024, but that's something that we want to keep an eye on heading into 25.
Aaron, the question I have with the Medicaid population, and you said that the market is shrinking. I'm questioning that premise because if I think about it, do we see the enrollment or the utilization of the Cook County Health System going down? So is it more of a shifting from the Medicaid, as far as I have insurance, over to the uninsured population? And sure, there's some that are going to go commercial, but there's some that have lost their eligibility and will then just fall into uninsured, and the system will be taxed with that without any compensation associated with their care.
Yeah, I think that's a fair point. I am only speaking specifically to the number of enrolled individuals on Medicaid, not necessarily how many qualify and are or are not signed up on Medicaid.
Thank you. Okay.
All right, the next slide shows
Those would be people that would be eligible for the exchange versus the
correct, yeah, depending on how their income's falling in a given point in time. So looking ahead, there's a few specific challenges as we are going forward. Obviously, the state's in a challenging budget environment, and the market's changing quickly, even since we developed these slides. The governor's budget proposal is now out and is proposing the elimination of the Healthy Benefit for Immigrant Adults program, which is a program that we have about 17,000 individuals enrolled on. The Healthy Benefit for Immigrant Seniors population, where there's about 5,000 of those individuals, is funded in the state's budget, but the current proposal includes the elimination of benefits for this population. The other potential significant risks that are out there at the federal policy level, which I know we've been talking about, there's proposals potentially around Medicaid work requirements. The other significant one is if the federal matching funds tied to the Affordable Care Act adult population specifically, which is funded right now by the federal government at 90%, if that is decreased. Illinois currently has language in statute, which they call a trigger law, which eliminates coverage for that ACA population unless the state steps in legislatively to make a change to that. So there's some big potential headwinds out there that we're monitoring now. And then on the opportunity side, there's the Health Choice Illinois RFP that I mentioned previously, which we're expecting to happen over the course of this year. I think we're really well positioned for that. And then the 1115 waiver which is approved and provides some expansion of services for Medicaid individuals, including areas such as housing, food, non-medical transportation, pre-release reentry services. All of those are things that we have been focused on as a health plan already, so I think this is an area of significant opportunity for us. Of course, there is, again, some concern that there could be federal policy changes that impact that waiver, but as of right now, that waiver is approved and moving forward, so we're continuing to watch the rollout of that.
Aaron, question on the trigger law, because I've been watching this. That concerns me. I'm looking at a number we have is around 413. How will that impact us?
So out of that 413,000, approximately 100,000 individuals are ACA adults.
That's
that
not
would
a
be
small
impacted
moment.
by that.
That's not small. That's roughly 25%.
Correct.
And so,
As far as our planning, we are assuming we will look at worst and best case scenario. I mean, it's a scenario we can't control. It is the legislation, it's what they do. So we'll have to figure out as part of this planning to adjust to that. You're exactly right. So what is the worst case scenario? And that would be a worst case scenario.
right, and so I look at it, it's almost two prongs, because we're gonna loop, and again, for the record, I'm not being a heartless person, but my role typically falls on the financial side, because that's the committee I'm on, or the human resources. So from the financial side, that's gonna hit the economic engine of the organization. And it doesn't stop there. I'm quite sure you know that.
We do.
And then it comes back and it's gonna so the question becomes, are there any safeguards so when it comes to hit the organization as unpaid care?
So we've been doing those exercises on the provider side, well, across the entire organization, actually. A 10%, 25%, and a 50% loss in revenue. Those exercises of kind of going through each person's budget and actually looking at what does that impact actually mean if we're gonna lose that much.
Okay.
So we're working through it. You know, we're hopeful still that the broader Medicaid cuts won't happen. There seems to be some, you know, push and pull, between what's gonna happen there. HBIA is looking a little more certain, and that's one that we're already, you know, looking at the bottom line impact on.
So the question I have, are there other opportunities to be able to shift that population to where there are revenues? Once they fall into that uncompensated, they no longer have insurance. I think we mentioned last time something about CareLink as a possibility and other things of the sort.
Yeah, CareLink does help cover costs for care, but it still is kind of a cost on our side. It's not true insurance, quote unquote, right? So, it really, I think, would be ensuring that we are, you know, when someone comes to us who's unfunded, we still want to provide the care, but as we shift towards kind of that pop health mindedness, right, it's more about avoiding the costs and doing what we can to avoid progression of disease and doing it at a more burdensome, more, you know, higher intervention kind of, you know, delayed care, right, where it's going to be more costly, it's going to be more burdensome on the patient, on the community. So ensuring that we're making that shift to be able to do what we can from a prevention mindset.
So then,
unfortunately, it's going to be cost.
sure, I understand that, but we're trying to minimize the impact of it.
Exactly.
So then that's where it comes to the question about, can we use the clinics as a way to get in front of it because of the preventive care?
Right.
And then that's where, it seems like every time I'm always saying something about Alex, but being able to get out to the community to try and get those folks in who won't come or taking the care to them, because they're gonna need it, and we're gonna have to do it one way or another. Right?
So, correct. So I think those are the kind of things that, as we're going through this strategic planning exercise, to think about what we do and how we do it.
So, real quick, the complications that you're sort of bumping up against, you have to look at it. One of the things that we've done since we started our Medicaid Managed Care Network was to help get people insurance or get coverage that we serve here, right? So we've been, and obviously not everybody covered by the plan gets their service here. And, you know, you've pointed this out in the past that we need to continue to work on converting people and getting people either to use the services here that we have or to convert them which, you know, we've talked about a lot, you know, which we've done a pretty good job of meeting that trajectory. But now, one of the issues is, as we look towards what's gonna happen in Washington, is we may find ourselves in a situation where we've grown our patient population under the managed care plan, because we were wanting to make sure we got more people coverage, and then the managed care plan gets pulled out from under us. So now we've grown that population, and now it wipes away. Now, some of it will be people we were gonna serve anyway, right? But the solution isn't necessary, at this point, I think one of the things we have to struggle with, like, one of our solutions, we don't know that the solution is going to be continuing to sign people up for the managed care plan. I think that's what we would wanna do, because it's what makes sense, and we wanna see all these policies that continue to exist, both because we're board members here, but also because we're community leaders, and that's, you know, having the social safety net. So this problem is, if you play it out 2 or 3 moves, as it can go in different directions, can become a quickly compounding problem. And I think the solution without any, if you were thinking about solutions without consequences here locally, right? Like, is like, oh, well, we'll just have the state, you know, lower the 90%, or just have the state supplement more into the Medicaid plan, which the state can't do it because the state's getting choked, we're getting choked off from the elimination of block grants and all kinds of other things are put on the budget. So, you know, this is definitely a critical moment. We've survived stuff like this before. We survived 4 years at the last part of the last decade, but I think that it's ramped up and attacking right now, they've backed off of Medicaid programs because it's not good politics for them. But they want to, so Stephen Miller is sitting somewhere right now in the White House, trying to design a way where he can flow Medicaid money, without violating the 14th Amendment to states where he wants to pick the winners and states where he wants to pick the losers. Ultimately, this will become a 14th Amendment equal protection issue in terms of how the Medicaid programs are deployed, because they're not going to want to cut Medicaid programs off to Alabama, Mississippi, and Arkansas, but they're going to want to disproportionately hit us and tie us to something like they're planning on doing, like Department of Transportation money, tying it to marriage and fertility rates, right? Like that's one of the things they want to do with the Department of Transportation that they've stated is conditioning motor fuel tax money on marriage and fertility rates. With any big city with huge universities is going to get clobbered by, because we bring in a lot of people who are, if they're going to get married, they may not get married for the 10 years that they live in Chicago, and they're probably not going to have kids. They're going to go somewhere else to do that once they're done attending school, and a host of other things. So this is a super complicated problem that is multi-directional. So I think
you're suggesting, which is interesting, that we should have almost like a watch board, and we have to put up there what are the legislations that are coming out, which group of people will it impact, how will it actually hit the
I think we're doing
words.
that. I think we're doing that. We're doing it, but yeah, that's the thing, is that we have to.
Moving target.
Yeah. So directors, I want to make sure we have a topic on the agenda. It's this topic, and we have 3 others to cover. So we can be here till the afternoon if you like, but you know, it's your choice. So I would suggest we move along. Thank you.
All right, and then I think this slide covers a lot of what we just talked about. So at the federal level, there's a number of different potential threats to Medicaid. There's, I think, more broadly, we're seeing individuals that have more experience with Medicaid becoming more discerning consumers in terms of patient preferences. And so there's a continual leveling up of the member experience that needs to happen in order to compete in this space. And I think we've made a lot of efforts on that front, but that's something that will have to continue to evolve over time. No news that there's inequities in health outcomes, and I think to continue to successfully operate in this space, there's going to be continued focus and investment on addressing those disparities. And then there's, I think, beyond concerns, purely in the topic of Medicaid funding, there's also a number of supporting organizations that also provide services to individuals that are on Medicaid in the community that also potentially could be impacted by federal changes in policy. So there's a broad swath of challenges there. And I think on the opportunity side, we are a very, as a health plan, Medicaid-dependent health plan today, one of the ways to reduce some of that risk is potentially to diversify the products that the health plan offers out to be beyond just Medicaid. There's different innovations and delivery care models that we're continuing to pursue in terms of things like hospital at home, a lot of the shifts inside of care that's happening, virtual care, things like moving dialysis in home versus an outpatient setting. Continuing to build partnerships across different sectors beyond just the purely health related sector to address more of the social needs of members, and doing that in a way that's focused and has the right ROI so that there's can be continual investment in that. And continuing to accelerate value-based care models, which we've been a leader in, but there's still a lot of opportunities for us to expand upon. And I believe that is my final slide. So happy to answer any final questions.
Otherwise, thank you. Dr. Nutter is going to come up and talk about the regional behavioral health strategic plan.
Welcome, Dr. Nutter.
Good morning. Given the preceding belief discussion, I guess it's appropriate that the mental health guy comes next. So Tom Nutter, Chief Behavioral Health Officer for Cook County Health. Thank you for this opportunity to present on the countywide behavioral health strategic plan that our team has been working on for the last several months. Today's presentation will cover the origins and rationale of the plan. Again, this is a countywide plan, not specific to CCH. We'll also cover the development of the plan, vetting of the plan, and then at a high level, each of the 5 priority areas of the plan. Having a countywide behavioral health strategic plan, i.e. a sheet of music that all agencies within Cook County can play their music from, has been planned even prior to the existence of the current Office of Behavioral Health. It makes sense in this time of crisis, the behavioral health crisis already existing before the current crisis mentioned earlier, that we all be working together to resolve gaps, address inequities, avoid redundancies, et cetera. And we as CCH, I think, are in an ideal position to do that as an entity. So the purpose of this plan is to improve collaboration across systems of care, enhance coordination of services across agencies, bolster collective advocacy, upgrade tracking and assessment of initiatives, and establish, again, I think this is the key, a common blueprint for all entities providing behavioral health services across Cook County. The vision statement for the plan is included here. Again, that's just to foster a healthier and more resilient county where all residents have equitable access to timely, comprehensive, compassionate, and high-quality behavioral health services. Next slide, please. I included this slide not necessarily to go over the guiding principles, but just as for full transparency that in these times, we obviously are who we are. We're not going to back down from who we are in keeping with the stance that TCH has taken. That having been said, we don't want to be so strident about saying those things that we put those we serve at risk. Next slide. The process for developing the plan has been a thorough one. I'll try to keep this as brief as possible. I've taken perspectives from hundreds of folks and from multiple processes as part of this plan. So we had the summit a year ago, which was a day of structured listening, a community needs assessment, which compiled several community needs assessments from other local health systems, as well as a survey of a couple hundred local stakeholders, a lot of publicly available data, the workforce assessment, which was completed back in, and presented publicly back in October. It was a very thorough assessment of our current environment. The workforce assessment and Summit also had their own steering committees that were with broad representation across sectors and geographies. As we use these, all this information, goals, objectives, strategies, tactics, and metrics were developed for each priority area. In the interest of time, we will not be going over all that level of detail, but I will point out you do have the full version of the plan that was sent about a week or so ago. Next slide, please. So there are obviously a number of governmental agencies, all of whom have seen that we're in a behavioral health crisis. And so one important priority for us is to be able to align our work with that of other agencies. So to ensure that alignment, we've had intergovernmental meetings starting back in August of 2024, in which we've presented previous versions of the plan to a group that includes not only folks from CCH and CCDPH, but also the Chicago Department of Public Health, the Justice Advisory Council, and an alphabet soup of state agencies as listed here. Following those meetings, again, and those meetings really didn't lead to a lot of major changes. No point in the process of this vetting has really brought about a lot of change in the overall structure. Just mainly changes in wording, some changes in tactics and strategies and organization. So in December, when we had the first round of meetings of the 11 regional collaboratives, there was mention of the plan, and then that plan was sent out in January to 1,200 community partners, and all submitted comments have been reviewed and are being incorporated into the final draft. And then lastly, to ensure that we had momentum and that there was widespread awareness of this, just in the last month, we had community forums on each of the virtual community forums on each of the 5 priority areas. The last one of these was held on Tuesday, I believe, this week. My days are running together. And total attendance at those sessions was approximately 500. Next slide, please. So this is a little hard to read, but the main point of this is that each of the 5 priority areas had strong representation in terms of the number of, this is the number of registrants there on the left. In terms of attendees at the actual sessions themselves, I think we were in triple digits for each of the 5. And then the right shows registrants by role, and you can see that there's a pretty broad group represented in the folks who participated. Pleased to say we had a little bit of a low turnout in terms of those with lived expertise at the summit itself a year ago, and a little bit higher participation from that important subgroup in this last process in the community forums. So next slide, please. So these are the 5 priority areas in the strategic plan: systems alignment, workforce development, prevention and early intervention with children, youth, and families, access to treatment, support, and recovery, and lastly, crisis system enhancement. So next slide.
I have a question.
Yes, please.
When you say systems alignment, is that Cook County Health System, or is it a broader system? That
More broadly. More broadly. Thank you for clarifying. So, and perfectly teeing up the next slide. Thank you. So this particular priority area really is the scaffolding of the plan. If we're going to be a convener and a coordinator across Cook County, we really have to have a network of communication that is local, both in terms of the way that we communicate from CCH, but more importantly, the information that we're gathering from the community. And so we've established, are in the process of establishing 11 regional collaboratives across Cook County, 6 for the city of Chicago and 5 for suburban Cook County. And we'll be continuing to meet with those groups in an ongoing way. We're planning on doing those quarterly, along with quarterly meetings of the intergovernmental group that was mentioned earlier. Again, for us to really be successful, we have to have networks that are communicating well, so that we really have hyper-local input into the processes and machinery as we go forward. Second goal among priority area 1 is to develop standardized metrics for data-informed decision support, planning, and evaluation, i.e. We need a dashboard. If we're gonna be all working together, we need to all be looking at the same things and the same, measures. So those are in the process of development, and, we'll be maintaining those, through CCH. Third, optimize resources and funding for behavioral health services and create a comprehensive and responsive behavioral health system. I.e., if you want to understand how something functions, follow the money. So we're in the process of putting out an RFP and to look at funds flow across the county, including some barriers, though obviously some new ones that are coming up as we speak, but also just in terms of more run-of-the-mill problems like certain services that are difficult to bill for community agencies and figuring out ways that we can collectively advocate on their behalf. Next slide, please. So this is just quickly a map of the regional collaboratives. The 6th in Chicago coincide with the health equity zones in the city, and the Cook County regions correlate closely with those used by CCDPH. Next slide.
I have a question.
Yes.
The city is very densely populated, and people are, and so when you talk about the suburbs, people are spread out a little bit more?
Yes.
Okay.
And that's part of why we split the
So our focus is
north
on
and northwest.
suburban Cook County.
Our focus is throughout
Throughout the city,
Cook
as
County.
a collaborative.
Throughout Cook County, period. Yes.
As a collaborative.
Yes. That requires obviously a great deal of collaboration with our colleagues in the city of Chicago, but yes, it's countywide, period. Next slide, please. So the second priority of the 5 is workforce development. These objectives are taken pretty much straight from the recommendations of from the Workforce Symposium from back in October. Provide competitive compensation, increase awareness of behavioral health careers, offer best-in-class community learn and earn opportunities, supporting local agencies for retention, and advocating for reduction in administrative burdens. What this will mean functionally going forward is on the provide competitive compensation and advocating for reduction in administrative burdens, we would be just joining other processes that are in place throughout the state for the increasing awareness of behavioral health careers and supporting local agencies. A lot of what we would be doing is using our platform to let the community know about other things that are happening within the community, and in particular, we'll be highlighting the work of the Behavioral Health Workforce Center at UIC, which is doing a lot of great work in this space. The piece that is unique to CCH will be creating this Learn and Earn Fund, which will we're hoping and have publicly said we're trying to get to a $50 million philanthropically funded fund that will provide opportunities for things such as paid internships for social work, those going through social work training, paid apprenticeships for those going through CADC training, funding for those in the LPN to RN ladder, those sorts of things that can address not only the significant gaps in the number of folks in the workforce, but address some of the issues we've had with poor representation of certain groups within our behavioral health workforce. Next slide, please. The third area is prevention and early intervention for children, youth, and families. And you'll see these goals look relatively vague. The important stuff, I think, is in the details. I think just in general, I don't purport to be a public health expert, but in general, the best use of dollar for dollar, the best use of funds is to invest those funds in young people. And so that's why we had 60% of the funding from the Stronger Together grants going to prevention, youth, and families, and why this will be an important part of the plan going forward. We did hear a lot of folks in the community saying they didn't really have good resource directories within their geographic areas, so we'll be working on those things. The state has been rolling out a new system. The Children's Behavioral Health Transformation folks have set up a new system, the Beacon system, that will be providing the opportunity to not only for folks to go online, find resources in their area, and also that system will provide us the ability to do some tracking of those in the system, which we don't currently have, so we're excited about that. Excited about rolling out more mental health first aid for youth, expanding screenings, monitoring the number of folks getting screened, and we're very fortunate to be able to have more than 400,000 covered lives that we can have quality data on through county care. So we'll be able to use county care core metrics for some of our tracking of efforts as we go forward. Next slide, please. The fourth area is access to treatment and support and recovery. I think we all know that access has been a problem really throughout the county, but in areas of historic disinvestment, that problem has been particularly jarring and particularly troubling. In a system that has as many access challenges as we have, I think it's important to set up structures that help folks at the front door. So our new upcoming collaboration with NAMI, already started but hasn't been publicly announced yet, to use the NAMI helpline as a front door for all outpatient services throughout the county. Not only helps with navigating that front door in a system that's very difficult to navigate at present, but it also gives us the ability to track access, because right now there's really no way to track how long it takes to get in for certain services throughout the county, and that lack of data is a significant problem. So again, we'll have the county care data to use as an evaluation of quality, and given that we are still in an opioid epidemic, reducing opioid deaths will also continue to be a priority of not only CCH, but something that we're assuring is on the blueprint going forward. And last slide. The last priority area is improving the crisis care system. I think we're all keenly aware that police aren't always the right folks to respond in the case of behavioral health crisis. I think we're all keenly aware that if one is acutely psychotic or suicidal, ERs are probably not a great place to spend a lot of time. And certainly, the criminalization of the mentally ill continues to be problematic, not only in Chicago but throughout the country. That having been said, streamlining some of these systems is a very tricky thing. The 911 system exists and functions in a certain way. The 988 system exists in a certain way, and the mobile crisis system exists. And we really want to help those systems to talk to one another a little better going forward. And look forward to using our space as our role as a convener to encourage some of those conversations and hopefully better coordinate some of those functions going forward. So that was a very high level, quick view of something that's immensely complicated. Two final things to mention. Since we do have the final bit of feedback from the forum participants just coming in now, the final version of this plan is not available yet, but you will have that prior to the next time we meet. And then lastly, I want to say a huge thank you to our team, particularly the leadership team who are here, Dr. Carlos Quintana-Gomez, Greg Lee, and particular thanks to Jennifer Brothers, who's just finished up really spectacular success with the community forums, for all their hard work. We have a really a leadership team of diverse expertise, but common purpose. So with that, I'm happy to take questions.
Director, any questions? Thank you. It's very thorough. I mean, to your point, 1,200 community partners you have to coordinate with, 500 sessions. Wow, 500 attendees. Wow.
Vascular service line.
So, directors, yeah, we're doing a service line update. So we have two. Yeah.
Good morning, directors.
Good morning.
My name is Rami Duki. I'm the director of the cardiovascular service line. I want to recognize my partner in crime here, Mr. Abu Ghazali. He's the business director of the service line. So the service line, the cardiovascular service line, kind of conceived, at the tail of the pandemic in early 2021, and we sought to develop a comprehensive, academic, world-class, equitable cardiovascular service line, spanning from prevention to complex heart disease. We did that through building new clinical services that we lacked, aligned clinical disciplines that's involved in cardiac care, from surgery, cardiology, radiology, anesthesiology, and others. And in addition to that, build quality on the services we already do. Next slide. This is a 5-year plan that we had back then in early 2021. I don't want to go exhaustively through this, but most of the things that we set out early on have been achieved. Examples of that, the structural heart disease program. This is the transcatheter valve replacement and other valve intervention through catheters rather than open heart surgery. Certain support devices like Impella device and electrophysiology services. We aligned clinical services that we targeted to include in the service line. We recruited for critical positions. We expanded our cardiovascular medicine fellowship program. We performed some lean projects, quality projects, and others. As you see, there are a number of things that have not been checked off. The green dots are for the checked marked, but the others are still ongoing efforts to complete those. Next. These are other accomplishments that were not on the agenda back then. One big one is opening a cardiac intermediate care unit. We lacked an intermediate or step-down level of care. We either put patient in critical care or a general floor, and we thought that this is needed. It kind of reallocated patients from the intensive care unit to the intermediate care where that might be the right level of care for them. We have been getting the American Heart Association Gold Plus, which is the highest recognition, and U.S. News and World Report high performance recognition for heart failure and heart attack care. Now for a number of years running, I lost count. Established external referral pathways. Historically, people refer to us only for uninsured patients. In the past 2 years, we started to get referral for the expertise we provide for insured patients, actually. And this is actually very important for us. We now receive a number of referrals from Insight Health, Sinai, St. Anthony. These are institutions that are not affiliated with major health systems. We expanded cardiology clinics to the community, like Arlington Heights, North Riverside, and Belmont Cragen. And we were the recipient of National Association of Counties 2024 Achievement Award. Next.
May I ask a question?
Of course.
When you look at the external referral pathways, what is our ability to fulfill that capacity need that they have versus our traditional people coming through the front door?
Well, these usually are select patients for select services that they do not provide. So usually these are direct communication. These are not they don't come by, in large numbers. So these are select cases. We do have the capacity to take them, and actually we would like to have more of them.
Okay, thank you.
Sure. Next. These are a number of things we achieved with the timelines of that, so I don't want to bore you through this. Feel free to ask questions. We're anticipating launch of the cardiac PET program hopefully in April of this year. This will be the third cardiac PET program in the city. This is a kind of cutting edge way to investigate heart disease. We're looking into building an ECMO program and cardiac rehabilitation program. Next.
Quick question on the cardiac rehab program.
Yes.
I've had it while that we can't let before. I think it's great that we're implementing one. Is that going to be located on site here in campus, or are we going to have any clinic availability or facility services? Those are definitely good services.
Yeah, we're looking into having it centrally. At least for now, that is the idea, and that's part of the challenge. We have real estate problems here. We don't have a lot of space. Cardiac rehab takes significant amount of space for treadmills and weights and whatnot, and also it requires a number of employees to run the program. Nurses, exercise physiologists, and others. And right now we have a kind of a little crunch on new positions.
I definitely think that
Yeah, definitely. This is one major aspect of cardiac care that we do not provide that keeps us from really claiming that we are a comprehensive cardiovascular center. So we've been advocating for this for years. I'm hoping this year we'll have better traction for it.
I would put that You only have a few for that, but I think that
Yep.
those are two line items that I
We,
think
we,
the service line
we
is
agree.
important.
Thank you.
Okay, let me ask the other question.
Of course.
I'm staying with the financial bent. On the cardiac rehab,
Uh-huh.
from a financial standpoint, how could that be a benefit to us?
Okay. I have to say cardiac rehab is usually not a big, winner, well, let's say, when it comes to financial performance. It is, however, it is a necessary, piece of cardiac care. And potentially most of the saving that you're gonna get are things that the things that you cannot bill for. These are the events that are prevented.
Yeah.
These are patients feeling well, therefore they're gonna need less, clinic visits, less events, things of that sort. So some of the financial revenue is not measurable directly, but the program itself, we would hope to, make a break even or make a little bit of profit on it. It is not a big financial performer, I have to say.
Well, here's the second question to that. If a person does come back in because they did not do cardio rehab, who pays?
Well, ultimately, to a large extent, we are, whether they're insured or not. If they're part of our county care plan, in a way, we are responsible for these lives. If they're uninsured and come back, we're also responsible for these lives.
So, he's not here. But the reason why I asked that question is because there's multiple ways that we can look at the revenue.
I agree.
Your first statement was about how much do we actually get from generating. The second is the cost avoided, because we're gonna pay one way or the other if we have the responsibility.
100%. You're preaching to the choir. I totally agree. It's a matter of, institutional priorities, I would say. We have been pressing on this for a number of years now. I hope that it would happen. We have by the way, we have a business plan for it, pro forma and the whole thing. It's a matter to allocating the physical space, which has been, tight in the main campus, and the positions that are needed to create the program.
The space is optional. There are other ways.
Yes, there are ways of virtual programs. I'm totally familiar with that. Not all patients
Agreed.
can do this. Actually, most disadvantaged patients probably are the ones who are not going to be able to participate. The advantaged ones, maybe we can get them into another program in another institution. So actually, we need both. I'm not arguing against it, but we need to walk before we run. It's easier to build it as a physical program. As we perfect that, I think then we can launch a virtual program as a second step.
I think you're gonna get better outcomes with a physical program. The virtual program depends on patients following through on the care that they're being provided virtually, right? For cardiac, so much of it is to do with part of it is like counseling, nutrition, things like that.
It's always part of it as well. What I'm saying is we need both, not either or.
Sure, agreed. A round robin could solve that too, because you can, well, we could talk later.
Okay, sure. All right, thank you. Next slide. I appreciate the attention to it because it's important to us. Generally speaking, we've been on good streak of growing our volumes. These are trends of cardiology clinic volume at Stroger per se, over the past, 7, 8 years or so. We pretty much doubled our volume. Next. Now we are locked in space a little bit. We cannot expand our clinic, because of, again, limitation of rooms and physical space. These are non-invasive procedures. These are just big highlights. EKGs, we do a lot of them, 58,000. It's been about flat or maybe 1% less than the year before. Echocardiography, transthoracic echo, went up by about 11% with the same resources. We did a lean project there that we optimized our throughput with the same resources. Transesophageal echocardiography is also growing up by, have been double digit for year after year. It reflects our growth in the electrophysiology space. And this is Holter long-term monitors. This is EKG monitors for patients at home. Also has been growing up year after year. Next. Advanced cardiac imaging. These are kind of new service lines we created within cardiology. Nuclear cardiology, cardiac CT have been growing. Cardiac MRI has been flat or a little bit down by 3% last year, mostly related to limitation in the cardiac MRI scanner. We hope to resolve this in the near future with expanding our MR scanners. Next. This is our interventional and cardiac surgery volume. Cardiac cath lab volume for coronary procedures went down by about 7% compared to the year before. This is a national trend, but also we believe that the IV fluid shortage has contributed to this. Some of the procedures have been deferred to January and beyond because due to the IV fluid shortage. Structural heart disease. This is a new program that we built as part of the service line. Has been growing in double digits year after year. Went up 41%. What is good news also that despite the growth of structural heart disease, we did not siphon away from cardiac surgery. Cardiac surgery also grew by double digits, last year compared to the year before. And the idea that when you have excellence and expertise, all boats rise together. It's not win-lose. It is win-win because we're expanding our referral base. Next. Electrophysiology also has been growing. Electrophysiology procedures can put in two big buckets. Device procedures like defibrillators and pacemakers, and ablation procedures both have grown compared to the year before. Next. Inpatient cardiology, and these are basically patients we take care of in the hospital. First, in the CCU and the cardiac intermediate care unit, we anticipated a little decline in the CCU volume because some of these patients will shift to the intermediate care where it is more appropriate for the level of care they need. So the intermediate care unit went up in volume and the CCU went down, but on net, to have a 12% increase of our inpatient volume of patients cared for by cardiologists. Our consultation volume went up by about 12% in general cardiology, and also the consultation volume at Providence went up by 3%. Next. These are our kind of to-do list for 2025. We would like to go live with the cardiac PET program. We continue to plan for an additional cath lab and electrophysiology lab. We want to have an ECMO program, cardiac rehab. We're going to continue to plan that. We want to expand our connections to other hospitals and systems to care of patients that they cannot care for. Optimize our operational efficiency and quality. We want to recruit for critical positions that currently are vacant. Optimize our reporting structure. We are building a heart failure service line. Advanced heart failure service line is an inpatient and outpatient services. And we would like to create a cardiac intensive care unit that integrates not only cardiology but also cardiac surgery, and potentially house ECMO. Build bridges with vascular surgery and interventional radiology. And we were planning a heart symposium. Initially, it was planned for the heart month. It was a little tight, so we were going to postpone it a couple months, but hopefully we'll do it, during this spring. Next. These are things to think about for the 26-28 strategic plan. I think there is room to expand electrophysiology beyond Stroger, potentially to Providence and also Blue Island. There's a lot of electrophysiology out there that we can probably care for. Build Providence infrastructure for cardiac care to be able to expand our services out there. Optimize the support, prior authorization, pharmacy, and things of that sort. Expand our non-invasive services in satellite clinic. This is something nice, bringing somebody from Arlington Heights to Stroger to get an echocardiogram. It's a little excessive in my mind, so there might be opportunity to expand our services where the patients are. We're working on a primary prevention population health, trying to prevent heart disease in the first place before it occurs, doing like a population level intervention. We're starting with Blue Island, kind of a testing zone, and then once we perfect it, we look into expanding it to the entire system. And I think that's all I have.
Thank you. A lot of work to do in 2025.
Thank you.
Yeah. Well done. 2024.
So Dr. Akintoran and Christina Urbina will present on women and children.
Thank you.
Good morning.
Good morning.
Directors, thank you for having me here. Certainly don't want to be in the way of people's lunch. The coffee might be wearing off and lunch might be ready. So we are very excited to be here to share the work that we're doing in the Women and Children Service line. We've got 10 slides that we'll go through fairly quickly, but happy to take any questions. So really, the service line approach that we take is intentional work to ensure that Cook County Health is viewed as a provider of choice, right? Not a provider of circumstance. The purpose goals, the vision, purpose, and goals are aligned with Cook County Health strategic pillars, and we work to create a pathway to improving care delivery and decreasing efficiencies for patient care experience. Next slide. Here you'll see, this is a visualization of the service line ecosystem that includes services within primary care, specialty care, and hospital care. So this is defined as an integrated service model by which we walk our work forward. Next slide. Here, again, we also have a 5-year plan, and to receive the full benefits of a service line model here in the health system, this plan focuses on, 4 buckets. So year over year, we look at operations, strategy, innovation, and programming to support wraparound services for women and children as screenings are done throughout their medical visits. Next slide. And how are we doing? So we always continue to evaluate the work that we're doing. Are we impactful? And here is just a quick scorecard sharing how well we're doing. One special call out for this slide is the red segment. So green means we're trending favorably and on time. Orange, favorably, but we've got some barriers. But the red is, this is the focus area, and that is maternal fetal medicine services, stabilizing, that service delivery model for our system, and then in the long-term future, to build a community service delivery model, as we know that there are some deserts on the south side that need services. Next slide. And to just in a high level, talk about some of the accomplishments that we achieved in FY24 within this service line. I'll just call out a few. As we look at the work that we do, the external partnerships, the enhancements, we have to revisit clinic staffing models, service deliveries, and so we've had to reimagine and reevaluate adjusting the staffing model for our pediatric clinic. So we're very proud about that. So Dr. Akintoran. The second is I want to call out number 3. So the suite of executed programs and agreements that we've been able to bring in funding through primarily grant services to support the social determinants of health and support adherence to care for both women and children in our system. And lastly, the $1 million from Tammy Duckworth to support some expenses needed in our NICU that Dr. Akintoran and ourselves are completely grateful for. Next slide.
Excuse me, before you move.
Yes.
So these are the grants that you highlight, this is actually the top 4. Are they federal grants?
They're a mix of federal, so the $5 million HRSA is a federal grant, and then there are some state grants in there. The NIH grant is a federal grant, so it's a mix.
Yeah, for sure.
State and federal.
Mm-hmm.
Thank you. Thank you. And then to share a bit of the operational aspect of the work that we do within this service line, this is some outpatient visit volume. You'll see, in the large part, favorable trends, year over year. A special call out on the prenatal volume. We see in 23 and 24, there's been a healthy, significant increase, in large due to just new arrival patients coming into our system over the year, and the demand for obstetrical care. And a great takeaway from this slide is really the efforts from the service line navigators. We have ancillary staff through the grant funding to support retention and adherence to care. For deliveries, well women care, pediatric care, here you'll see the retention rate for deliveries. So you'll see the metric on expected delivery volumes, and some might ask, why do you put expected? These are women who are receiving prenatal care within our system. We expect them to deliver at Stroger Hospital, but that doesn't always happen for multiple factors. And next slide. And here on this slide, you'll see some volume on the hospital side. And so these are the actual deliveries, from the expected to the actual. and this is supporting the retention rate, which we hover about 70%. And you can see a favorable trend. And this year, we've experienced about a 30% increase in deliveries within our healthcare system. And next slide. And to review planned activities. So what is on our path going forward for this year? I'll just call out some focus areas. One of our top priorities is really recruiting and building that maternal fetal medicine staff, the program, and the services. That is the red area from our scorecard. That is a priority that's supporting not just obstetrical care, but our NICU care, our peds. We are launching our doula program, and we were fortunate enough to get $1 million into our healthcare system and it's an innovative approach, right? Hospitals don't typically hire doulas. Doulas are usually provided from the patients themselves or community organizations, so we're really excited to launch that. And starting late March, early April, we'll have the first cohort of doulas into the system. Expanding urogyne services, so women have, a life before pregnancy and after pregnancy, and so touching some of those urogynecological services that we're expanding, not just at Sturgis, but primarily at Providence. And then as the work continues in the pediatric realm of the service line, Dr. Arcatoran has been extremely successful with her partnerships with external partners, bringing pediatric subspecialties to our organization, and that will continue with the external collaborations, putting our neonatology team, or placing our neonatology team in other external hospitals to support neonatology gaps in other hospital systems and support any transfers into our system to receive that ongoing care in our NICU. Next slide. And lastly, some of the items under consideration that were not pre-planned, but we certainly are trying to weave in to the strategy as we move forward. And I'll just call out a few of them. One, to establish an accreditation for our ultrasound unit, which is, again, supporting the maternal fetal medicine rebuild and expansion of those services in our system. And we would really love to continue investing in prevention for pediatric and adolescent health. Dr. Nutter mentioned some of those efforts through behavioral health, but we need that in medical services as well. And the other is Families in Therapy Program for Pediatrics. That was a program that we had in our system. Unfortunately, funding was lost for that. But as we know, the external environment is, revealing a lot of need for families and young adults and kids that need therapeutic services. And I believe that is it. Any questions?
On your women and children's FY '24 inpatient volume, on the actuals, you have 1156, and for the NIC admissions, you have 304.
Yeah.
I see the increase on the NIC. My question is that linear to the increase of the volume of people?
Yes. Typically, you have about 20%. If you have like 100 newborns, like so the more newborns, the more newborns you have.
I understand it's gonna go up, but my question is it representative to the number? So if we look at the previous years and look at the increase or the decrease, did we see that symmetry happening at that time?
No, another thing is that the issue is not only dependent on the diseases we have other hospitals that we cover, and so we have transport from those hospitals.
Okay.
So I have a question as well. You mentioned the launch of the doula, so we see funding for the grant. Do we have funding for ongoing beyond launch?
So it actually wasn't a grant, it's operational.
So we have operational funding, we
Correct.
built it into the budget for ongoing? Okay, great. Want to highlight that. Thank you. And then, of the under consideration, you list a number of them. Which is most doable?
Which is most doable?
Yes.
I wouldn't pick one. I would actually pick two.
Okay.
One would be
Which two?
the accreditation for MFM. And I would say one of the pediatric ones in therapy, I think.
So we can do a lot. So why don't we focus on the most two that are most doable and build from there?
Absolutely.
I'm sorry, one being directional. I would suggest that you focus on the
That's
two
fine.
that are most doable and build from there.
That is why I highlighted those.
Not my role to tell you what to do. Yes, you have a question.
And, I mean, of course, there's a lot. I love what you're doing with the doula program. We know, like, yes, it is sort of a pilot. We're looking into it, but we know historically certain communities actually do better with doula. So, thank you for that.
You're welcome. We're excited for it. Building trust back in the hospital system.
Are we measuring, after birth, I can't remember the correct terminology, but for the different visits that should occur?
We are. So you're referring to postpartum visits.
Yes.
So these are HEDIS metrics, right? So post-delivery, that is one of the noteworthy items on that slide that our navigators help with. So we're trending at about 89% of women who deliver here are completing their postpartum visit.
Wow.
And what we're actually doing through one of the grants in partnership with NIH is it's called a Step Up Grant, where it's something that we weave into our operations anyway, is we go beyond the postpartum visit. So actually linking them to a PCP within 3 months after that. Because we know when anybody, and we're talking about women here, are connected with a primary care provider to go on with Well Women Care, the complex conditions that may not have been caught, that might have created an unhealthy pregnancy, will be caught then.
Yes.
And we're supporting that Well Women Care for any additional pregnancy, should she want to have them or not. So their contraception, their screening for cervical cancer, so really ensuring and educating women to make themselves a priority for ongoing Well Women Care. So we look at postpartum and we look at linkage to PCP after.
So are they coming back here for care?
That is, we would like them to. However, if they don't choose us, we really continue the advocacy to get linked to care.
Very good. Excellent.
Thank you so much.
I, just one, I swear I'll keep it short. I get a lot of questions about, what we're doing to support, access to abortions and, making sure that as the, climate around it is shifting in terms of more attention, states, restricting women's access to abortion. I don't see it necessarily called out, as much in this as I think that the, advocates would like to see it called out. So I just want to highlight that as we're looking at this, and obviously we're going to be, there's going to be, pressures to even though we've quote unquote put it back into the states, that there's going to be, people trying to mess with funding and access to abortions, even in places like, Illinois, so.
Well, I can address that. Currently, we have two fellowship-trained family providers, and we've recruited a third one that will join us in October, and we just completed interviews for the director of family planning. We've gone through construction here in the hospital to make that more accessible, so it's not tied up with the operating room, so completely independently of adding that whole activity on for that, and other organizations don't have that. So I think we're in a good place for this, the tempest that was going to come. I think we're in a really good place. All right.
And if I may just kind of add value to that a little bit too, there's a lot of talk about that we definitely have access, and it's right, it's part of women's health as a right to care. But we also, at the same time, through the family planning lens of this, do a lot of work on prevention, right? Prevention and education. We are now an FPPE provider, it's supplemental Medicaid program plan, that is supporting greater access for women, and including men, coming into any system to get coverage for things, contraception, vasectomies, hysterectomies, STI screening, STI treatment, all of that. So at the same time, simultaneously, we're supporting those service offerings and the access, prevention and.
Absolutely, family planning services are contraception are definitely important. I think that people feel more insecure about their access, though, to, when you're one step past that, so.
And we're here to support.
Thank you. I appreciate it.
Thank you very much. We
Thank
appreciate
you.
thorough updates for
Was there-
both service lines. You have another question?
No, thank you.
Thank you.
Okay. Andrea, anything more? No? Okay. Thank you, directors. I know there was a lot of information. I appreciate the extra time. I know we're trying to stay on track with the, strategic planning, timeline that Andrea presented last time, so I appreciate the extra.
And
Time to
assuming
get
that
through
we
it.
will stay on track
We will.
with the timeline. We agreed to it, we're gonna do it. Thank you, Andrea. All right, directors, we had two other things on the report, but we're gonna move those. So just given the time, we'll do the CCDCH quarterly report in March, and then, we'll cover additional items in our briefings. Do I have anything else? All right, thank you. As the agenda is exhausted, the chair declares this meeting adjourned.